This toxicology curriculum is brought to you in collaboration with McMaster University, Western University, and the University of British Columbia. This part of the Toxidromes section will focus on Digoxin. By the end of the session, you should be able to describe the slow and low toxidrome and give some examples. We will review the toxicity of cardiac glycosides and formulate an approach to managing Digoxin toxicity. Let's go through a few cases. The first case is a 72-year-old man presenting with dizziness, chest pain, nausea, and blurry vision. His heart rate was 34 beats per minute, blood pressure 70/52, respiratory rate 12, temperature 36 degrees Celsius, and an oxygen saturation of 92% on room air. An ECG is done in the emergency department and shows the following. Describe this ECG and think about what toxidrome this could be. What types of exposures could produce this clinical picture? We're able to gather some additional information about this patient. His past medical history is significant for hypertension, congestive heart failure, and atrial fibrillation. His medications include furosemide 40 milligrams daily, Digoxin 0.125 milligrams daily, and hydrochlorothiazide 12.5 milligrams daily. The medications have apparently not changed recently. He has, however, had a recent diarrheal illness. Lab work was done and shows a sodium of 140, potassium 3.4, creatinine 230, Vid1 8.9, and a digoxin level of 5.4 nanomoles per liter, drawn 8 hours after the last dose of digoxin. Our next case is a 42-year-old woman brought in by EMS following a suicide attempt. She was found in her room by family members, somnolent, surrounded by vomitus containing pill fragments. A note at her side suggested that she had ingested multiple pills approximately 4 hours prior to being found. She had access to a number of medications, including propranolol, amlodipine, clonazepam, digoxin, and acetaminophen with codeine. Her initial vitals were a heart rate of 42 beats per minute, blood pressure 72/48, respiratory rate of 18, oxygen saturation 92%, and a GCS of 8. During her initial resuscitation, she went on to develop an asystolic cardiac arrest. What toxidrome fits with her initial presentation, and what ingestions could lead to this clinical picture? Then think about how you would manage her cardiac arrest. Both of the patients in these cases presented with a slow heart rate and low blood pressure, consistent with a slow and low toxidrome. There are a number of exposures that can lead to a slow and low toxidrome, including beta blockers, calcium channel blockers, cardiac glycosides, including digoxin, cholinergics, alpha-2 agonists, opioids, and sedative hypnotic agents. Both of our cases presented with the slow and low toxidrome, and both of them had exposure to digoxin as one of the medications. The first case is an example of chronic digoxin toxicity. The second case is an example of acute toxicity, including digoxin, as well as a calcium channel blocker and a beta blocker. As you'll see in the next few slides, digoxin toxicity can be acute or chronic, leading to different presentations and important differences in management. Let's remind ourselves how digoxin works. Digoxin is an example of a cardiac glycoside. Cardiac glycosides cause inhibition of the sodium-potassium ATPase pump on the surface of the cardiac myocyte. This leads to increased intracellular sodium, which reduces the sodium-dependent calcium transport out of the myocyte. The resulting increase in intracellular calcium concentration produces the increased inotropy and automaticity that is clinically useful. Because the sodium-potassium ATPase pump is blocked, this also leads to decreased transport of potassium into the cells, resulting in hyperkalemia with acute overdose. Cardiac glycosides also have a vagal effect on the heart, which inhibits the SI and AV nodes, causing bradycardia and heart blocks. Cardiac glycosides, or cardioactive steroids like digoxin, can be found in a number of pharmaceutical preparations, as well as from plant and animal sources. Digoxin is the most common source of exposure in North America, but other preparations are available internationally, including Digoxin and even wabane. Oleander, as well as yellow oleander, also contain cardiac glycosides. Yellow oleander, in particular, is commonly used in Southeast Asia as a form of suicide. Other plants include foxglove, lily of the valley, dogbane, and red squill. Bufo toad species also contain cardiac glycosides. There are some key differences in the features of acute and chronic digoxin exposures. Acute digoxin toxicity can present with nausea, vomiting, and abdominal pain within minutes to hours of exposure. Lethargy, confusion, and weakness may also be present. There is a wide variety of bradyarrhythmias and tachyarrhythmias that may be seen with digoxin toxicity, and these can be accompanied by hypotension. Hyperkalemia results from decreased transport of potassium into the cells by the blocked sodium-potassium ATPase pump. The presence of hyperkalemia actually has prognostic value, with potassium levels greater than 5 having an increased risk of death. Chronic digoxin toxicity has a more insidious onset, often in the context of concurrent illness with acute renal insufficiency. Some of the features include weakness, anorexia, nausea, vomiting, delirium, and confusion. Similar to acute toxicity, a wide variety of bradyarrhythmias or tachyarrhythmias may be present, as well as hypotension. Visual disturbances such as reduced visual acuity, altered color perception, or the classic xanthopsia, where there are yellow halos around lights, is more classically seen with chronic digoxin toxicity. There are a number of bradyarrhythmias and tachyarrhythmias that can be seen with digoxin toxicity. It's said that any dysrhythmia, except a rapidly conducting supraventricular tachycardia, can be seen with cardioactive steroids because of their prominent AV nodal depressant effects. Bidirectional ventricular tachycardia, when seen, is considered to be almost pathognomonic for digoxin toxicity. The definitive therapy for severe digoxin toxicity is digoxin-specific antibody fragments such as digifab. Indications for digifab include cardiac arrest, a life-threatening dysrhythmia regardless of serum digoxin levels, potassium level greater than 5, an ingested amount of digoxin greater than 10 milligrams in adults or 4 milligrams in children, or an absolute level of digoxin of 15 nanomoles per liter. In chronic digoxin toxicity, treatment can be considered if associated with dysrhythmias, significant gastrointestinal symptoms, or altered mental status. Digifab can also be considered for patients that have been poisoned with a non-digoxin cardioactive steroid. These slides have just been a brief introduction to digoxin toxicity and how to manage it. The following questions will help to further your understanding of this topic. Number 1, when is the appropriate time post-ingestion to measure serum digoxin levels and why? Number 2, describe the dosing of digifab, both empiric and calculated. And number 3, when is it appropriate to measure digoxin levels after digifab has been given?